All right, so we have another online speaker next. I'm pleased to introduce Monica, who is uh, at Royal Brisbane. Are you at Royal Brisbane at the moment?
Yes, but at the moment I am in Munich.
That's what I was just trying to work out. I was just wondering where you were. Okay, so Monica, thank you very much for joining from Munich. She leads the Translational Kidney Pathobiology Group at Metro North Kidney Health Service, and her research interests include kidney disease epidemiology, biomarker discovery, and chronic kidney disease management.
Thank you to the organizers for inviting me to speak. So today we'll have a brief chat about leveraging registries to advance transplant research, or research in general. So the primary role of registries is to help with health infrastructure planning, particularly because it can quantify disease burden, which can also inform preventative strategy development. And importantly, registries also enable one to audit service practice patterns, evaluate service quality, which then can be used for benchmarking and providing regulatory oversight and as part of the continuous quality improvement. For example, units get an annual report for the Australian New Zealand Dialysis and Transplant Registry yearly. But more recently, there's also been secondary use of registries, and particularly this involves doing research that can be hypothesis generating, and particularly you can look at data to support randomized controlled trials, and you can also do big data analysis for the creation of prognostication tools or scoring systems. And they can also be very useful for real world trials where the registry data is able to reflect actual medical practice, and includes populations that are not represented in clinical trials, either because they're multimorbid, or kidney failure patients also end up being excluded from a lot of trials. And you also have longitudinal follow up over a long period of time because these registries are often collected um, for service monitoring purposes. And you can see here that there's a rising use of registry studies over the past 20 years. Um, and that's because there's increasing recognition of the value of registries and research. And also, this graph likely underrepresents the number of registry studies out there, particularly because this graph goes from 2000 to 2020, and also because it excludes clinical trials that also used registry data. So, the strengths of registry data is that it can provide population level cover, particularly if it's an administrative data set, because you generally get near complete follow up. Um, and you can also end up with quite granular data collection depending on the registry. And the other useful thing is that if registries are collected for a similar purpose for a specific condition, um, there are similar variables being collected across multiple registries, and that can allow you to do inter-region comparisons. Although some attention does need to be paid to exactly how and the formatting of the variables are, and that would be come in as a part of the study planning part of it. And also the longitudinal follow-up, and you can end up looking at sort of both medium-term and long-term outcomes after an intervention or in a specific population, which would be quite resource intensive if it was to be done as sort of primary data collection. But there are limitations of registry data, and particularly because the data is pre-collected. So a lot of it is already preset. Some of it is because of selection bias, and that's particularly if you don't have complete follow up or complete collection. And it is possible that people who participated in a registry may be different to people who did not participate in a registry. So in that way, it's quite important to understand how the registry works, whether it was opt-in or opt-out, and whether it was a administrative collection, or whether it was the resourcing and what percentage of the population. So there are some registries where it's only public health data, and then there's some registries where it's only private health system data. And it's just sort of understanding what the constituents of that registry data is. There's also an issue with confounding factors, particularly because we don't know what we don't know. So there may be some variables that may impact on your outcome, but weren't measured. There's also can be an issue with missing data, particularly if some variables were not collected completely. And you're highly dependent on the quality of the data collection that has already occurred. And there's certain checks that you can do to check when you're doing your data analysis. And there can also be variability in data coding, particularly in how people have categorized certain conditions, whether people had it or not, and that sort of thing. So here's a few examples of how registry data has been used. And you can see from the previous graph that I'd shown that there's been quite a lot of registry studies. So this is certainly not an exhaustive list, not a complete list, and more just to provide some examples. So registry data has been used for epidemiological research. You can use it to look at rare diseases, and they're particularly useful for that because you end up getting the case numbers and the power that you need to do an analysis. And also you can look at outcomes in specific cohorts. You can look at outcomes of therapy if it was included in the registry. And particular with Anne's data, you can look at outcomes after kidney transplant, outcome after live donor kidney transplant, or particular immunosuppression regimens. And there's been some studies looking at sort of whether steroid-free or steroid-containing immunosuppression regimens after kidney transplant in immunoglobulin A nephropathy recipients impacted on their later disease recurrence. And registries can also be used in pragmatic clinical trials, either to help with patient selection and also for follow-up after a clinical trial to reduce data collection burden. And we'll go through a couple of examples now. So the first one is a study that we've done looking at medium-term, short-term and medium-term kidney transplant outcomes. And for this study, we extracted data from the Australia and New Zealand Dialysis and Transplant Registry, particularly looking at first kidney transplants in people greater than 18 years old between 1995 to 2014. And we classified the exposure in 5-year intervals. The covariates are as listed. The primary outcome was 5-year all-cause graft failure. The secondary outcome was 10-year all-cause graft failure, as well as cause-specific graft failure. And this study included about 10,000 patients in the analysis. What we were able to find was that we were transplanting higher risk donors and recipients. And this was particularly because recipient age had increased over time. The percentage of people with with diabetes, coronary artery disease, peripheral vascular disease, increased dialysis vintage, as well as higher BMIs had also increased over time. And there were also an increase in the number of HLA mismatches as well as donor age over time. There was also a change in immunosuppression regimens, particular reduction in cyclosporin use, with an increase in tacrolimus use, reduction in azathioprine use with concomitant increase in mycophenolate use. And despite transplanting those higher risk recipients, there was improvements in 5-year all-cause graft failure. And on the left, you can see sort of adjusted survival curves. And you see that the survival rate or graft survival rate increases from 1995 to 1999 to 2010 to 2014. And that's also demonstrated on the right with the adjusted hazard ratio as well, where we use 1995 to 1999 as a reference, and the adjusted hazard ratio sequentially reduces over time. The same was also seen for 10-year all-cause graft failure as well. And this is an example how you can use single registry data to look at sort of medium-term and long-term outcomes after a therapy. Next, we'll go on to an example of how registries were used in a pragmatic clinical trial. So this was work done by Michael Collins and his team through the BEST fluids trial. And this pragmatic RCT was double-blinded, registry embedded, and conducted across 16 hospitals in Australia and New Zealand. And particularly, they were asking the question whether balanced crystalloid solution reduced delayed graft function compared to normal saline. And they were able to find that there was a reduction in the rate of delayed graft function in people who had balanced crystalloid compared to normal saline. There was no changes in the number of dialysis sessions or duration of dialysis session, and no difference in graft function recovery. And the way this study integrated registries into their protocol was that they used data collection through the ANS data registry. So there were custom built modules for trial specific data collection. And there were also overlap between the standard ANS data collection and the data that was collected for the trial. And then adverse event data collection also occurred through hospital administrative data sets as well. Randomization was implemented through a web-based FlexiTrials platform via ANS data. And specifically, the data that was collected from ANS data included demographic data, donor characteristic data, and long-term follow-up data. And this enabled a reduction in the burden of data collection for the trial. And because ANS data also includes almost all transplants that occur in Australia and New Zealand, the investigators were also able to demonstrate that the population that was used in the clinical trial was also demonstrated overrepresentativeness of the transplant population in Australia and New Zealand. So in Australia and New Zealand, we have sort of 4 main registries, and down the bottom on the right-hand side, there's a QR code for the ANS data website and for these registry websites. So specifically, there's the dialysis and transplant registry, the organ donation registry, the living kidney donation registry, as well as the eye and tissue donation registry. And these websites are all quite informative and have a lot of information about the variables that are collected, data dictionaries, how data can be requested from these different registries for your research, and also contact details should you have further questions or want help with developing your protocol. Internationally, this is more specific to kidney failure registries and transplant registries from a paper we did a few years ago where we surveyed international kidney failure registries. And here are the locations where there are kidney failure registries with the details about sort of what sort of data is available out there about the variables that they collect in case you want to do sort of multi-region analyses. And we classified it as whether the questionnaire or data entry form was available, whether the variables were available from a registry report or from previous publications, or it's directly listed on their website, and also whether the registry was developing or inactive or uncertain status. More recently, we've moved towards asking the question of, well, what is the pre-recorded data that is available for nephrology research generally? And this work was led by Owen S. Sullivan at the Royal Brisbane and Women's Hospital. And we surveyed the types of data repositories that are available. Some of these data repositories you have to request data, some of it is directly downloadable from the original website. And on the right, there's a QR code to access nephronexus.com. And I encourage you to take a look if you ever want to do sort of nephrology or transplant research, because there's quite a few data resources there. And particularly, we collated national and international data registries, disease cohorts, biobanks, omics atlases, single cell and genetics data sets, as well as AI training data sets. And then the QR code for the article about it is on the bottom right. So what about if the registry does not have all of the required variables to answer the question that you're asking? There is also the opportunity to do data linkage, which is where you can link data from multiple registries together. And here's an example of it that was led by Sean Chandler and Menon Palamuthasingham. They asked the question of whether bariatric surgery outcomes in patients on chronic kidney replacement therapy in Australia and New Zealand led to higher incidence of kidney transplantation, as well as adverse outcomes such as mortality. And what they did was they did data linkage of ANS data, which has all the data on people on kidney replacement therapy, with hospital admission data sets, which collected the bariatric surgery information between 2000 and 2015. And then they compared the people who were on kidney replacement therapy and had bariatric surgery with people, a matched non-surgical group. And they were able to find that there was a higher incidence of kidney transplantation amongst patients who underwent bariatric surgery, and that bariatric surgery was associated with lower hazard ratio of death. So I'll just finish off with a few tips and tricks for utilizing registries for research. First one is data dictionaries. Often these are on the registry website. They're very helpful because they're able to tell you the start dates and end dates of how particular variables were collected, as well as the format and how the variables were classified, particularly for categorical variables. And these can change over time, particularly for long-standing registries. The other thing is ask for help early. It saves a lot of work later on. And registry staff are great because they know the registry data sets very, very, very well and can help you with designing your protocols. Biostatisticians, because they can help you design the statistical analysis protocol, and that also affects the data that you request originally as well. Local ethics and research governance officers are great for helping with working out those processes, as well as being able to help with sort of particular data linkage studies, how to navigate potential issues, as well as colleagues who have done registry studies before. And for data linkage, there's two great resources out there. There's the Population Health Research Network, as well as the Australian Institute of Health and Welfare, who do data linkage. So here are a list of collaborators and funders. We're thankful for all their assistance and support.
I will move on. Thank you very much, Monica. Really appreciate you joining online. Thank you.